Shakira Najwa binti Muhammad Nazimi and my matric number is 081640. Our group have chosen to explain about the epi-shoulder projection. Today, I'll be presenting the technical factors and patient positioning for an epi-shoulder X-ray projection. Let's begin with the technical factors. First, the source to image distance or SID should be between 100 and 130 cm. This is essential to ensure accurate image magnification and optimal image quality. Next up, the image receptor used is typically sized 24 by 30 cm crosswise. However, in cases where the injury extends into the proximal half of the humerus, we can replace the receptor lengthwise to include more anatomy in the image. Next, a moving or stationary grid can be used depending on the setup and patient size, which helped reduce scatter radiation and improve contrast. As for exposure setting, we use a KBP of 70 ±5 and an MAS of 6. These parameters help produce a clear diagnostic image without overexposing the patient. Lastly, cornet shielding is important for radiation protection. Several types are available, including flexible cornet shield, gonad or ovarian shield, and apron with snap buckle or metallic ring closures, all designed to minimize radiation exposure to sensitive areas. Let's move on to the patient positioning. The patient can be placed in either an erect or a supine position. However, if possible, erect is preferred because it's less painful, especially for trauma patients. If standing, the patient should have their back facing the image receptor, which allows proper alignment of the shoulder. In some cases, it might be necessary to rotate the patient body slightly toward the affected side. This ensures that the shoulder is in contact with the receptor or tabletop, providing more accurate diagnostic image. The image on the slide illustrates how to center the X-ray beam properly over the shoulder area to capture the best possible view. In summary, proper technical settings and precise patient positioning are both critical in obtaining a high-quality shoulder radiograph. By following this guideline, from selecting the right receptor size and exposure settings to careful patient handling and shielding, we can ensure both diagnostic accuracy and patient safety.
My name is Nur Adira Binti Roslan with number matric 081597. So let's begin with the part positioning for the epi-shoulder projection. So firstly, position the patient so the scapulohumeral joint is centered to the receptor and slightly abduct the extended arm. Now, depending on the type of rotation required, the arm is positioned differently. So for natural rotation, the arm remains in natural position, typically with the palm facing inward. For internal rotation, rotate the arm inward until the hand is pronated and epicondyle are perpendicular to the image receptor. And the last one, for the external rotation, rotate the arm outward until the hand is supinated and epicondyles are parallel to the image receptor.
Assalamualaikum. My name is Nur Aina Nazira binti Azmi. My matric number is 081703. So, now I'm going to present about my part, which is center ray of epi-shoulder projection. Okay, so for the central ray of epi-shoulder projection is perpendicular to the image receptor. The central ray must be direct to 2.5 cm inferior to coracoid process or 2 cm to the lateral portions of radially palpate clavicle. Next, the collimations of epi-shoulder projection. For the consummation of epi-shoulder projection must be include the entire shoulder joint, encompassing glenohumeral joint, proximal humerus, and also scapula. You can refer to this anatomical structure for you to identify which the anatomical structure that I mentioned. So here is glenohumeral joint. This is proximal humerus and this scapula. Other than that, central ray and centre of collimation field should be at scapulohumeral joint.
Hi everyone, my name is Nur Fahisha Kosrina binti Muhammad Sohardi, and today I'll be presenting the image evaluation of the shoulder X-rays, which will be focusing on the three standard shoulder positions, which are the internal rotation, external rotation, and neutral. First of all, let's start with the internal rotation. This view shows a lateral projection of the proximal humerus, the lateral 2/3 of the clavicle, and the upper scapula. It also demonstrates the interrelationship between the humeral head and the glenoid cavity. In terms of positioning, full internal rotation is confirmed when the lesser tubercle is clearly seen in a full profile medially, while the greater tubercle is superimposed over the humeral head. This view is particularly useful when evaluating the lesser tubercle or suspected subcoracoid dislocation. Okay, now moving on to the external rotation. This is an AP projection of the proximal humerus. Like the internal view, it includes the lateral 2/3 of the clavicle and the upper scapula, which is along with the glenohumeral joint space. So, full external rotation is confirmed when the greater tubercle is visualized in full profile on the lateral aspect of the proximal humerus, while the lesser tubercle is superimposed. This position is ideal for detecting the greater tubercle fractures or calcifications. Okay, lastly, we move on to the neutral position. So the neutral position shows the upper scapula, the lateral 2/3 of the clavicle, and about upper 1/3 of the proximal humerus. In this view, both lesser and greater tubercle are superimposed by the humeral head, which is typical when the arm is in a relaxed position. So, it is natural position at the side, and this projection is usually chosen when the patient is in pain and unable to rotate their arm. To summarize all of this image, for internal rotation, the lesser tubercle is seen medially in full profile, while the greater tubercle is superimposed. While for external rotation, the greater tubercle is in full profile laterally and the lesser tubercle is superimposed. And lastly, for neutral position, both lesser and greater tubercle is superimposed by the humeral head. So each of these projections plays a key role in assessing different aspects of shoulder anatomy and possible pathology. Thank you.
Now, I'll be explain about the clinical indication for epi-shoulder projection. So, epi-shoulder projection is commonly indicated in the several clinical scenarios, including trauma cases, fractures involving the proximal humerus clavicle or the scapula. Thirdly, defect on the posterolateral surface of the humeral head, often associated with recurrent anterior shoulder dislocation. And the last one, cases of the osteoarthritis. So this projection helps in accurate diagnosis and planning for treatment or intervention.